So in truth, I haven't seen it implemented yet. However, I'm very intrigued. I've worked with several risk-bearing MSOs, and so essentially these are organizations that do the governance for physician groups, and so providing all the services that one would typically find in a health plan, but tying together those independent physician practices. And so one of the things that we're always looking at and even discussing with the health plans in the contracts that we have is around spend. And I really think that there's going to be a focus. There already is a focus, but more and more because of the changes with quality, the changes with V28. I think the compressed margins, we're going to see more and more emphasis on total cost of care. And I see the Teams program to be another experiment, if you will, that CMS is providing for traditional Medicare and for those, as part of like their ACO programs. And so one of the things that I do have experience with is working with medical groups. And, we would look at things like, were they able to do, say, joint replacements or, knee and hip surgeries? Could they do those at an ambulatory setting or perhaps somewhere else where it might be less of a cost as opposed to in the hospital? And so when I look at the Teams program, it makes me think of that. It provides solutions for that. And so essentially the premise of the program is to provide an episode-based payment, similar to how I think about maternity care. And so folks may be familiar with, when someone is pregnant, all the visits that are associated with that pregnancy until a certain time are covered under one payment. And what that does is it requires the physicians and the health system that's supporting that mother through her maternal care. It forces them to really think about the care that they're providing and doing their best to manage cost. And so the Teams model is similar to this. There's 5 procedures that they identified, including what I had mentioned, the hip joint replacement, spinal fusion, and a few others, some bowel surgeries. I'm assuming that they're meaning hernia surgeries and things like that. But providing an episode-based payment on those. And so the intent would be to, once the patient is identified as needing that procedure, managing the costs at the hospital, and then also making sure to coordinate, it would be on the hospitals to then coordinate back to the PCP for, additional care that patient might need. The Teams model provides or allows for, there's 3 different tiers as far as the risk that a hospital can take. The first and second tier obviously are less of a downside risk, whereas the third one would be, in my mind, more equivalent to what we see with like global risk payments. But it covers the procedure, all the visits that would be associated with the procedure, as well as 30 days from the procedure. And it requires hospitals to make sure that the patient is then connected back with their primary care. And I'm not surprised by this. I think it not only goes by total cost of care, but one of the things that we've been hearing from OIG and CMS is how do we demonstrate continuity of care? So making sure that specialty, the hospitals and that primary care physician are all connected, so that that patient, right, is getting that seamless, integrated care that's important to their health and wealth. I think some of the challenges will be, so what I found in the years of making that transition and moving from a fee-for-service system into a risk-based system, I think it's a few things. I think that you have people that are familiar with a particular type of system in the past, And so, hospitals were paid for procedures. That was their bread and butter. And so I think that, that paradigm shift of how we're thinking about payments will be important. And with that will be the emphasis on care. And I think that without having the infrastructure in place, to your point about, collaboration being important, we know that silos, even in, risk-based systems are still a challenge. That collaboration is going to be important. The way that I would look, I've heard some really interesting contracting strategies across the industry. So I think that, that could be important, but I think that, for ACOs and for others to connect with their hospitals. I think that there's lots of opportunity too for hospital systems. And so I think that, having those types of strategic discussions and looking to ensure or network and encourage those conversations so that you can have those types of relationships is going to be important. If you don't already have good relationships with your hospitals or with, your primary care or your specialty within your area, that those conversations are going to be important. And I think that, I just came from a conference, Value-Based Care Summit, actually, where we were talking about, having those discussions with, say, specialists. And sometimes it's not so enticing, right, to enter these risk-based relationships. They had experienced, like I had said before, they had experienced a different type of payment. And so it really requires a paradigm shift. And so how can you be creative in the incentives, for managing that care? Because that's the whole premise of this teams model, is managing the care appropriately. I mean, some people are going to need maybe more assistance in that traditional hip replacement, say, because that's one of the 5 conditions that they're targeting, at least in the launch of this program today. You know, um, there's a typical spend that should be associated with that. There's a pretty typical standard of care of how that goes. And so, managing those costs, not to say that there couldn't be an anomaly, but more often than not, there's opportunities to make sure that, and that was really the emphasis, I think, of the Teams model too, is, making sure that the patient is connected with care. Because a lot of times what we find is that a patient goes in and has a procedure, they're, released from the hospital, and a lot of times they go home, and they don't have appropriate follow-up care. They may not have the appropriate supports. And that's one of the things that the Teams model stresses, is that the patient, the hospitals are making the referral to the PCP and making sure that those visits are happening. And so I think that, there are opportunities to have discussion around, what's best for continuity of care, and then having those relationships. I think that can be fostered through good strategic contracting, and then connecting, right? Because that's what the model hinges on, is making sure that you have those connections. So I think that in and of itself will help drive the collaboration. Also, too, in some of the tiers, there are incidents where if you're participating in this program, if you don't manage care well, you could end up paying monies back to CMS. And so, it behooves you to do the best that you can to manage those patients. I think that the things that would be important are going to be technology, and so having data at the point of care, and then having ways to communicate. Um, there's a lot of silos in our system. I know we were just talking about collaboration, but still, there are a lot of unconnected systems. Not that sometimes, point solutions aren't helpful. I think they can be because they're developed in a way that's, very specific and important, for the work that you're trying to do. But there needs to be a way to connect all the pieces so that you have good communication. And so when I think about this, this program, it's going to be important that hospitals have access to that patient's entire medical history. It's going to be important to understand, as you're releasing patients back to their home, uh, what their environment looks like. Is it an environment that's optimal, right, for their recovery? And so having data around social determinants of health, I think would be important. And then also too, being able to communicate that information to the primary care, and then the primary care too, to have an understanding of what the patient experienced, say in the hospital, or having the ability to connect with a specialist if something were to go wrong. And so I think that I think that it's a very innovative program. I think that it's an important program, especially working in risk-bearing medical groups for many a year. This was something, and these procedures too, quite frankly, are the ones that we talked about time and time again, of where there were opportunities to control costs. So it's not surprising to me to see the five that CMS is choosing to focus on. But I think that it's going to be important. And again, I know I mentioned some of the conferences that I was at, but one of the messages that I heard that was loud and clear, and there were representatives there from Health and Human Services and a few other organizations, is that interoperability and having access to data, real-time data, that's important for patient care, is going to be an imperative. We really need to have that information if we're going to do the things that we're wanting to do. I haven't seen any. I'm sure that there are some, but I'm just becoming familiar with it myself. And so I would want to table that opinion so that I have a little bit more time to reflect. But I'm sure that there are opportunities within. Whether or not those loopholes will be good ones remains to be seen. But I think that yeah, I think, looking at the program on its face compared to what I've experienced working as an executive at a risk-bearing medical group or several medical groups in that capacity, I think that this is an important program. And I think, unlike some of the networks, I've been a part of strong networks where they did have a very good relationship with their hospital, and there were incentives that were built in managing that care. I haven't seen that everywhere. And so this puts it as part of, it's integral to the program. So I think that that's important, and that will help it be effective, so that maybe there won't be as many loopholes. But again, would like some time to ruminate a little bit further and to see if my opinion changes. I do think one of the things that I am thinking, and like many folks, I think know, I get around to a lot of conferences, and so just hearing the talk and knowing to just reading the industry news, there's a lot of health plans that are exiting, say, Medicare Advantage. There's a lot of new strategic relationships being formed. We have lots of new ACO programs. I do see healthcare shifting, and I think that all the programs that we see coming from CMS, uh, very interesting. If I were to read the tea leaves, right? Getting the opportunity to hear OIG, CMS, CMMI, HHS talk, there's a common theme in their conversations around the importance of patient care, being patient focused, having that continuity of care. And I think more and more you're going to see an emphasis on what our clinicians and our provider groups can do, our healthcare professionals, that includes hospitals, that includes specialty, but what they can do to improve care for patients. And I think that there is definitely the belief that the focus needs to be um, first on the primary care physician, because, I think they're seeing and treating most of our, most of the people. But then also too, that recognition that specialty care and hospital care are important. No, I would say that we're definitely going to see a shift in the field of healthcare. Already, we've seen in the industry papers that even just in the last few days, there's been an announcement of a lot of health plans choosing to exit the Medicare Advantage space. I think the emphasis is going to be more and more on these ACO organizations. And I think with all these creative and innovative programs that CMS is coming out with, it's obvious. And in listening to them speak to over the last several years and getting to participate in different, caucuses where we're having these discussions, there's definitely a push to have more of the I can say more of the activity happening with the providers and the clinicians, and putting more power in their hands to govern what patient care looks like. And so really empowering, I think, physicians, so primary care and specialty alike, as well as our hospitals and other sites of care, to do their best work as they see fit for the patient. And so hoping that with all the different components, I know that, some of the programs are providing money for investment for these provider groups to, add to their infrastructure to be able to do these programs, and to the point that I made about interoperability and support the things that will be necessary, right, to be successful in these programs. Those are the types of things that I see happening to our industry, and the trends that I'm anticipating is that, again, you're going to see more local control or governance in the hands of clinicians, and definitely a greater investment in technology that provides data at the point of care, so that it can be used and is actionable for bettering and furthering good patient care.